end of this question. So which of the following imaging studies should be ordered to streamline this patient's care? So nothing straight off the bat that helps me look at that. Looking over my answer choices, ultrasound, bone scan, okay? I got my general idea of what's going on. So back to the top. 22-year-old male presents to the emergency department for 1 hour of right knee pain after a twisting injury while playing basketball. On exam, the patient has a positive Lockman's and a positive anterior drawer. Screening radiographs, there's a Sagan fracture. We've already talked to orthopedics. They need to see the patient. Well, what imaging study should I get for my patient on the way so when he gets to orthopedics, they have an answer? And they don't have to say, well, we'll see you in 4 more weeks after you get your MRI. So what do we think this patient has? This is one of those order questions that skips a level.
ACL.
ACL. Which of the following is the specific physical exam test that would confirm the suspected diagnosis? And I've got this injury with a red arrow and a yellow dot at the knee. What have I got here? Ooh, a fader. Okay, those are hip tests, patellar apprehension, Lockman's, knee test, Ober, covers both. Okay, so let's head back to the top. 32-year-old male presents to the clinic complaining of atraumatic pain in the area indicated below. Pain is worse with running, downhill, and cycling. Patient is tender to palpation just proximal to the lateral joint line where a 1-inch wide tissue is prominent. Which specific physical exam test would confirm this? Okay, so that 1-inch wide tissue prominent above or proximal to the joint, lateral joint line, that's the IT band. So we're going to find an IT band physical exam here, and so we're looking for that Ober. Faber is going to test hip labrum. Fader is going to test anything that we had that was femoroacetabular in terms of internal rotation pain. Patellar apprehension comes a lot more in today's conversation. Lockman's is the ACL test. Which of the following is a potential adverse outcome that a patient should be educated about? Okay, looking over those hallux rigidus, we haven't talked about it. Ankle dorsiflexion contracture. Okay, maybe. Fallen plantar arch, well, there's a lot of foot things. Post-operative wound opening, deep vein thrombosis. Okay, well, they all sound like they could be complications to something. 33-year-old male was diagnosed with a high-grade gastroc tear that is being treated non-operatively in a cam boot for 4 weeks. Okay, so adverse outcome for the treatment, immobilization, is that thrombus formation. So DVT. We also have to watch the gastroc. Gastroc had a lot of overlap with pain location for DVT as well. And so that was one of our precautionary notes on the physical exam as well, was to differentiate the two. Typical primary osteoarthritis of the knee would result in which of the following knee deformities? Genu varum is the correct answer. When we talked through that, it has to do with wear, sanding down of the spacer between the where we all bear our weight. So when we bear our weight through the medial compartment, what everybody does, unless they have a deformity to begin with, they sand that down over time, and over time that joint space would narrow and they would get genu varum. Let's block one material. Which of the following directions is the force, the mechanism of injury in a patient with a lateral collateral ligament tear? And this is where Captain America came in. Nice job there. So we need to stretch the lateral collateral ligaments. We need it to go around a bigger curve. So if we put force here, sorry, that's at the classroom. So if I need to apply force, then that is trying to, the lateral collateral ligament is trying to go around that longer curve, and it will tear. Following is a treatment for a complete ACL tear in an active duty service member. It is reconstruction. Physical therapy alone, that was for our low demand, doesn't do anything with their ACL, is never going to run laterally. Excision alone would leave them still deficient of an ACL. So if they were debriding, that's a thing. It would be weird, but a thing. Straight leg immobilizer for 6 weeks, please don't do that. They will end up with, they'll lose all their range of motion and they will become a poor surgical candidate. That was why we talked about the range of motion brace and the ability to bend your knee when you get in the car. Same can be said for a cylinder cast. So it is exactly what it sounds like, a cylinder that is applied to your lower extremity. Medial or typical knee osteoarthritis would result in which of these bursa being irritated? Pes anserine. So again, we talked about that one being right under the medial hamstrings, but irritated by those bone spurs that form as part of the osteoarthritis process. Greater trochanteric bursitis, that's IT band people and people who have pressure on the side. Infrapatellar and suprapatellar, we only barely spoke about either of those because they're deep to the patellar tendon and quad tendon, in that order. And they are a lot harder to irritate because of their protected location. And then pre-patellar, we talked about that one was housemaids, where they crawl around on their knees. So people who lay tile or carpet, who crawl around on their knees all day long, those types of people. Which of the following types of claudication gets better with cycling, does not resolve immediately after activity stops, and works from proximal to distal? So gets better with cycling, increases the oxygen demand, but it's getting better. So that one takes my vascular off right away. Confirmed, does not resolve immediately. Sounds like once the oxygen demand goes away, it doesn't get better. Confirms, proximal to distal, just throws that final nail in that one. Neurogenic. Which of the following imaging modalities would be helpful in assessing for other pathology in this patient? Oh, well, I wonder what this patient has to begin with. A 26-year-old male who presents to clinic for follow-up after an acute knee injury 1 week ago. He has been treated appropriately to this point and reports he has been compliant. On exam, there is pain at the medial joint line and laxity with valgus stress testing. So what do I think is going on? MCL something. Screening radiographs are normal. Which of the following imaging modalities would be helpful to look for other pathology in this patient? So that's still our MRI. What would we be looking for? To anything else, right? Okay, so meniscus tear, other comorbid tears, PCL, ACL, cartilage damage, sure. We'll leave it there. CT with arthrogram. So we didn't use the arthrograms as much at the knee as we did at the hip. We did that a lot at the hip. So that's kind of why that particular answer came up. Last one. Which of the following ratios is abnormal and should be evaluated further? So anything less than 0.9 is bad and needs to be evaluated. 1 is the normal value. So that's where the brachium and the ankle are the same. And that would be cool, right? It's probably never true, but it would be our 100% option. Switch over. Okay, so the last thing that we left off with last time. No clicker for me. Oh, clicker there. I found clicker. Hey, clicker. Okay, so where we left off was talking about the meniscus. Any concerns about the meniscus before we proceed on? Very well then. Our next topic is going to be osteonecrosis of the femoral condyle. And taking things that we learned about from the hip, osteonecrosis is going to have to do with altered blood supply and an altered ability to heal at that femoral condyle. So it's a segment of bone that's lost its blood supply. How do we get that? Usually with some kind of systemic disease or change that alters their blood flow, and then we throw trauma onto it, and so it hurts that area. Where is the most common? Weight-bearing medial femoral condyle. With our discussion about osteoarthritis just a minute ago on that quiz, just start to insert how bad that is. We all bear weight for our medial joint. So these guys are starting to change that at a crazy rate. So some of the diseases that it can be associated with, so it can be idiopathic or steroid therapy. That came up before. Renal transplant, lupus, sickle disease, Gaucher disease. Additional information on who it happens to: women more than men, and those who are older than 60. Both. Okay. There on the right is kind of an illustration of what's happening. So we're starting with some subchondral damage. So just to orient you to our map here. So this is the medial femoral condyle. Here's that tibial plateau. And we're getting damage deep to that. And initially it doesn't change anything at the surface, because remember, we care the most about the cartilage that's here. But once it gets to this point, it's starting to crack open as it expands, that bubble expands. And they'll get a plate that covers that, that's kind of the body is trying to close that, trying to make it solid. It's just not strong enough. And then you'll have a halo around the outside of the lesion where the body recognizes that there's damage and is trying to heal it, just like fracture healing. But eventually you can't stop that pothole's there, no matter how many patches you put on it. And it'll eventually start changing the biomechanics right at this area, meaning every time they drive their little car over their pothole, it becomes irritating and inflamed and will result in overgrowth of bone, cartilage healing, inflammatory properties, all of that stuff. So why do the patients come in to see us? Sharp pain in the medial compartment. This isn't the achy toothache pain that patients with osteoarthritis complain of. This is stabbing knee pain. They are, and it's not all the time. It's like when they run over that area and it becomes, that open area is exposed, then they get that sharp stabby pain. It's mostly there in a background, low-grade type pain, but it will get worse the more times they irritate or run their condyles over the tibial plateau. So again, this is sharper than that background pain we described with osteoarthritis. So if you tweeze it out with some history questions, that may become clear. Adverse outcomes of the disease, kind of from that picture, we looked at that subchondral collapse, which changes, makes that pothole, and then causes the changed biomechanics and increased forces. That all leads to faster osteoarthritis. On physical exam, there's inflammatory processes going on, so they may have an effusion, loss of range of motion, and because they're choosing to change how they do and do not use their knee, they may develop a contracture. So it's usually in the flexed position because that's how we sit in our cars, at our desks, in front of our TVs, all of that stuff. So it ends up being a little bit bent if they've been like that for a while. If I do an exam of their knee, and I'm looking specifically at that tenderness to palpation, the area that we're talking about is on the femoral condyle, so you can feel your own femoral condyle, and my patella is here. So you can usually put your finger close to that lesion and be able to palpate it there, just medial to the patellar tendon. So we start with plain film x-rays. So we may be able to see that sclerosis around the injured area that would show us that the body's trying to get in there and trying to heal the area. As it advances, you might be able to see flattening of that condyle. Instead of having that nice articular arch, it will start to be flattened. And then once you get into the osteoarthritis, you're going to see that just start to crazy go out of hand and get to that joint space narrowing and osteophyte formation, maybe faster than you would expect for that 60-year-old female. Once I look at them, let's talk that picture first. Okay. So here's our fibula, so that tells us lateral. And the area that we're looking at is here. So it should be nice and well-rounded, like this lateral condyle. But on this one, I love this screen because it doesn't like me. Sad face. So we're looking at, wow, what I do now. You guys like watching us do this, don't you? Professor cannot talk to screen. Okay, so we're looking at this area right here. Can you appreciate if there's a white ring around this area in terms of the density of the bone compared to the other side? Obviously right here it's pretty white. This is really, really white. To the point where I'm starting to lose all the canals, the alignment. So that's our lesion right there. Then I'll take that to an MRI because I need to know about the surviving cartilage. What is actually left in this knee? How much bone do we have? Does the body even know that something's wrong there? So confirmatory tests, I think what's going on, but I'm going to check it here, evaluate for related injuries, identifying the lesion and predicting its progression. So what do I see on this MRI? That is not where I see it, just so we're clear. That's the other end of the pen. There we go. Okay, hold on. I learned this last time, didn't I? Oh. So in that area is the osteonecrotic section. We've got bone edema outside of that. We do actually have some cartilage down at the bottom that's still surviving. It's keeping on. So good job keeping on there, cartilage. And that can tell me as I scroll through, I can see how big that bubble of necrotic tissue is and move from there. Not great options in terms of surgical or non-operative management. So we can try to limit their weight bearing and their loading of that joint. We have braces that can do that. They can call medial offloader braces. They switch the weight bearing from the medial compartment to the lateral compartment. So that's what an unloading brace is. Anti-inflammatories, if there's crazy inflammation, we can do that steroid injection to calm that down so that they can get in with therapy. And that aqua therapy, because it's not weight bearing, like it's not like walking or jogging or cycling or anything like that, can help them be able to increase their fitness without increasing their loading and therefore their pain. Surgically, we can do a couple different things. So arthroscopy, they can go in and try and get the body to recognize that that area is deficient and poke through that osteonecrotic bone and trying to get it to heal more aggressively. We can do an osteotomy where you go and you realign what the weight-bearing surface is, so switch it from that medial compartment to the lateral compartment. Or you can just get a knee replacement and get a whole new joint, and that'll go. There in that picture is the exposed. I'm sure that they're doing an arthroplasty here because there's no reason for a knee to be exposed quite like this unless they're taking it off. But that's that big pothole lesion there with the red inflammation. Let me go more centrally and I'll highlight those things. So this is the lesion, but we can see that there's irritation all through there as well. Kind of creepy. So who do we need to get over to orthopedics? Well, we can give them a go at non-operative treatment, but if they fail that, they should head over to orthopedics for evaluation of one of those concepts. Questions before I move on? Okay, we're going to start all of the patellar or quadriceps things now. So we're going to start with tendinitis. What we're talking about is the extensor mechanism. I will say that several times as we go through this set of 4 pathologies. So extensor mechanism means that it's the leg extensor. So when I fire my quads, pulls through the quad tendon, through the patellar tendon to the tibial tubercle to extend the leg. Okay, so extensor mechanism. So tendinitis. I'm just amused at myself. Tendinitis. It's got lots of I's and not quite so many O's. In fact, I think it's spelled wrong right there. Don't think I know. What are things I still need to fix? Okay, so what is it? Extensor mechanism tendinitis, you guys may know it as jumper's knee. So something up front in that extensor mechanism. So they can have pain either. It is usually not both. Just there's usually a weak link in the chain. So they usually don't get pain at both of these locations, usually one rather than the other. So quadriceps tendon at its insertion at the superior pole of the kneecap. So that here, this ridge right at the top of my kneecap. Or the patellar tendon at the inferior pole, either at the inferior pole or at the tibial tuberosity. Okay, so one of those locations. These are generally younger patients because they're doing things like playing basketball. Jumping or kicking sports, so something where they're using their quads a lot, usually forward-backward type stuff rather than side-to-side stuff. Jumping, or they have, that's such a nice way to put it, Robin, erratic exercise habits. So we talk about the text affinity for the phrase weekend warrior or weekend athlete. If they're not having a steady load to their quadriceps, then maybe they're getting this type of complaint. If they're older, it may be a lifting strain that happens when they're doing something they shouldn't have been, a change to their exercise level, increasing those quad active exercises, maybe for weight loss, and thus corresponds with substantial weight gain and their desire to get it off. All of these things that have to do with the patella will have anterior knee pain. So although it says hallmark there, that's hallmark meaning it comes from patella or quadriceps. Begins immediately after exercise, which sort of makes sense, right? They're using it, therefore it gets abused and irritated. It will also, if they exercise and then they sit down and take a load off, then they will get this as well. Because we have other things that happen. So worse with knee extension activities, which makes sense, right? Anytime I activate my quads, so any of those activities, running, squatting, jumping, stairs, all of those are things where I'm using my quads pretty extensively, getting my patellar tendon, quad tendon involved. Again, it's anterior knee pain, so that sitting preceded by exercise thing could have to do with, like, we would consider long car rides or theater sign. Though we tend to use that phrase more with patellofemoral pain syndrome, which we'll talk about in a few minutes. Adverse outcomes of the disease: it hurts. Rarely do they tear the tendon. So we'll learn about kind of the play between tears and tendinitis as we continue this discussion. Okay, so physical examination. I'm going to check for tenderness to palpation within those tendons at those 3 locations. And be pretty specific. They may have some swelling or some soft tissue, crepitus. Those bursa that we talked about, infrapatellar, maybe there's some irritation around there from it being smashed. It's harder to appreciate because, again, it's underneath the patellar tendon. The next one is a good extensor mechanism check. So if it's intact, they should be able to do resisted extension. We do that during our just normal physical exam. Remember when we were testing strength, kick out? Okay. If when they're doing their kick out strength test, they have pain, especially anterior pain, that would help us narrow it down to this pathology. And then if we flex it way extreme, and we take that patella and we smash it into the trochlea, that may also be painful. let's see here, resisted extension is what is in the big picture on the far right. So it's not a technique that we usually talk about, but they're kind of elevating it up to that kind of gentle 45 to 60 degree bend and then saying, okay, now push pressure, try and kick me out. But you can do it from the seated position like we learned here too. Okay, plain films, we always start with those. AP lateral of the knee will help us get a good idea of what's going on with the patella. Enthesiophytes. Okay, so remember, enthesiophytes happen in a tendon. That's where the N part, enthesio is tendon, it's actually attachment. So bone within an attachment. If they have that at the tibial tubercle specifically, they may have a history of Osgood-Schlatter. We don't get to use that phrase anymore because they're grown-ups, but we can maybe muse about it in our own private musings. Did you have a history of this? Okay. MRI, we usually don't need it unless there's something above and beyond. They failed non-operative treatment, but just for the tendonitis, there are no indications for MRI. So let's talk about enthesiophytes. So this person in the middle picture has them at both the arrows, positive arrow sign. So the tendon is pulling so hard on the bone that the bone and the tendon are defending each other, defending against that pull by building more bone, because bone is strong. It's not as flexible though. And then here on the right we have that ossification within the distal tibial tendon, which is typical of Osgood-Schlatter. So what do we do about it? Okay, well, we start with our non-operative stuff. That made sense because I said there's very rare need for that MRI. So anti-inflammatories, rest, ice, compression, elevation, change in their activity, physical therapy. Once they are getting through that and they have that physical therapy and they're regaining pain-free range of motion and flexibility, then we proceed to strengthening. And that has to do with the quads and the hamstrings in terms of balance. But just note there's like an actual order in this one. So we do those non-operative rest, that's the same things we do for the first time and across most of our pathologies. Range of motion, then we move on to strengthening, and then they get to go back to their regular activities. They will be stronger for it. Adverse outcomes of treatment. So if we give a steroid injection to calm down that pain and we give it poorly, we can do a tendon rupture. And then sometimes there's just there's impairment that lasts. That slide kind of showing some home exercises that can be done to work on the extensor mechanism. Those are mostly strength exercises. Pause there. Go ahead. I would say if they aren't proceeding well with physical therapy, so it's kind of like a 2B. So if they're going through and they're doing their flexibility and we're maybe ready to start strengthening, but they're not, their pain isn't under control, then we could kind of sideline them off to do a steroid injection to help them continue physical therapy. Okay, now we're going to start rupturing things. It's kind of cool. Okay, so patellar or quadriceps tendon ruptures. Extensor mechanism, so disruption of the extensor mechanism can happen. So there are 3 ways we can do this. So although the heading is patellar and quadriceps tendon ruptures, there is a third option that is a complete patella fracture. Okay, meaning that it's disrupting that extensor mechanism in a similar way. When we do our physical exam to one of these patients, if it is a complete tear or a complete fracture, they will lose that ability to do their extension. Like there is nobody else in the knee who extends it. So it's not like some other stabilizer, like we've talked about all the other knee stabilizers. There's no other knee extensor. This is it. So if they can't do that, it becomes worrisome. How do they get it? Or a fall on a partially flexed knee. There's lots more F's in there than P's. Direct blow causes a fracture, so if they land directly onto their kneecap. Who are they? So if it's a quad tendon, go ahead and muse about this. Why? Why is it a different population? Okay. Quadriceps tendon, white men, middle-aged. Patella, black men, middle-aged. What does it matter? I don't know. Some builds differently. Clinical triad. We love triads, don't we? Okay, palpable defect. That means that you can stick your finger in it and you're like, ew, that's gross, there's a defect here. Inability to extend that knee and a change in their patella height on x-ray. And I'll show you what that means momentarily. If you don't fix it, they don't ever extend their knee again. So they can't look, they can't sit, they can't do anything. Large effusion, it's a big injury. So large effusion, palpable defect, again, if you run your finger down it, there will be a gap. It's gross. And then no extension against gravity or with a straight leg raise. So even if you extend it out and say, okay, keep it up there, keep it up, keep it up, keep it up, they're doing a because there's nothing holding it up. So let's see here. That's what's depicted in the far right picture. Wow, when I look that direction, I get super mic. Okay, so that one's him trying to do active extension, but you could, like I said, you could do the eye straighten it for them passively and then try and get them to hold it, and they won't be able to do that either. We need an AP and a lateral. We also kind of do an oblique of the knee, and we're going to talk about patella alta and patella baja. Hopefully you've heard these terms before. What I want you to consider in this system is that the system is always under tension. So as if I am holding, the quad is trying to just gently pull at any point in time. So if I rupture the patella tendon, the quad's going to win out, and the patella, because of its location, is going to gradually slide higher. It's no longer tethered down. So it will be high. Alta means high. Baja means low. Okay, so if I'm pulling on my same quadriceps, I'm pulling here, and I hack the quadriceps tendon, this part springs and this part goes because it's no longer being suspended. It sinks down. It is low. You'll see I have the next slide is kind of showing them next to each other so we can start to look at those levels. And then here in this picture we have that complete patellar fracture. Those fragments stayed mostly where they were, but they're being pulled apart just a little bit. So that kind of shows the natural tension, but this is the third variation on this. MRI is rarely necessary only because we can see it with radiograph, and thereafter they get fast forwarded. So let's take a look at this set of x-rays to determine how we figure out what high and low is. So as we look at this green, and we kind of look at where our measurement is, we definitely, it's still here in the trochlea as far as the higher part is. And, oh, can't scribble quite that much. This line right here kind of is our lower normal. This picture is taken a little bit of flexion, but that would be our low normal. So when we look at that trochlea ends right here. The patella has no trochlea to talk to, and it's very lonely up there, far north. And then when we look at, sorry guys, that line, all of a sudden I'm touching that patella. So it has been pulled inferiorly. And almost appreciate that down here. There's not a whole lot of patellar tendon there. Kind of should speak to us. This is one of my favorite rads. I have no idea where that came from. Okay, is that a piece of bone that came off of right, oh, not right there, right here, maybe. It could just be some ossified something or other that was associated with the injury too. But you probably saw that picture previously in Brad's class. Okay, so Alta and Baja. I'm going to pause there, let you muse for a second. Okay. Questions, concerns? Go ahead.
Do you get bilateral like this?
Yeah, if you could. So, like, if this one were like, you're like, oh, well, that's bottom of normal, then yeah, you could totally compare it to the other side and be like, oh, yep, that's super far down. Doesn't belong there. Go ahead. Rad techs do that part for you, so yes, but don't go down that rabbit hole. Engage more quads equals more pull, and you can get a higher alta. Okay, proceed then. No big surprise here. Okay, so rare and only for incomplete is that non-operative treatment. So I would proceed with my normals, anti-inflammatories, rest, ice, compression, elevation, activity modification, and physical therapy. Knee immobilizer versus cylinder cast. Luckily for you guys, that's not your call. Okay. So even just to get this cylinder cast part, you got to send them to ortho. But we'll probably go with something else. Operative, all complete ruptures or fractures, please, within a week. Otherwise it starts getting tethered down, the quadriceps, the patellar tendon gets tethered down to something else and becomes very, very hard and shortens and shortens and shortens until we can't get it long enough. Post-operative infection, this is a big incision. These aren't our tiny little arthroscopy incisions. Thromboembolism due to the amount of immobilization, see immobilizer / cylinder cast. And a re-tear within the first 6 months is a risk because of the fibrous nature of the scar tissue that forms, which is not as resilient as the organic tissue. And then there in the bottom we have what it looks like to do, that one's a quad repair. So there are tunnels that they drill through the patella and they run sutures down it, and then they get in there and you've got surgeon A with the quad and they're pulling back, and surgeon B with the patella in that section, and they're pulling it together, and then some sore stop in the middle is like trying to tie it off before they give out if they're all at muscle failure. Okay, so we get it back together. The poor stop is usually the resident. It's fine. Okay. All complete ruptures to orthopedics within a week. Incomplete ruptures are concerned to orthopedics. Not quite as emergently, but get them there sooner rather than later. Okay. Patellofemoral maltracking. You guys remember when we were doing our imaging and I was like, wait, why am my world getting rocked about this trochlear groove? I don't like getting up in here in front of you guys and being like stumbly in words and say wrong things and pictures labeled differently than the words. So I went and I did some reading about this particular sets of complaints. And when we were in that same lecture, I was talking about how we like the femur on the same plate to be able to tell the amount of rotation. It comes down to that. So that longitudinal rotation, I can't do that within, oh, well, maybe I can do it with Captain America. No, because it's in his knee. But if you take that long bone and you imagine that it's rubber in the middle and you can turn it, that twisting is called torsion. And people who fit into these maltracking have a different twist to it. which is why my understanding of the knees and the trochlea was more biased towards one being higher than the other. Because when I go and I do a sunrise view, the patients that I'm looking at are already, I'm thinking this, otherwise I wouldn't get that particular x-ray. So they're more at risk. So my sample size in my head was here rather than the person who was captured in the radiology imaging in that sunrise view, which evidently has a different twist to their femur. We will talk about that same twist to the femur when we get to in-towing and out-towing. So I was at least knew something that this could happen. But that's kind of the origin of why those trochlear bumps can come at different heights for different types of people. So we'll take it from there. Okay, so abnormal position of the patella, which changes the stresses on the cartilage. So on the front of the trochlea, which is that groove at the front of your, oh, see, I'm going to take my tendon off. So trochlea's this part, okay, cartilage here, cartilage at the back of the patella. If we change the pole, we change how the cartilage interacts with each other. On that picture where the blue arrow is, you can appreciate that there's next to no pole, like those two cartilage surfaces aren't even talking to each other. Whereas where the red angry sign is, those surfaces of cartilage are spending way too much time in intimate discussion and are very agitated. So again, this is a set of conditions, abnormal motion of the patella. It can range from subluxation to straight dislocation. So there are two types of dislocations of the knee. There is a patellar dislocation and there is a tibiofemoral dislocation. When you're taking patient histories, you should try and elicit one or the other, because one is a big deal and the other is lesser of a deal, and the lesser deal corresponds with this topic. Instability is lateral. We kind of talked about that during the radiology discussion. So pole muscles on the outside are stronger than those on the inside, so pulling it over a smaller bump becomes more possible, especially if there are tears to the anchors, and we'll talk about that in a minute. And then, oh no, we'll talk about that right now. Medial patellofemoral ligament. So it does connect the two things it says. So it's medial, it connects the patella to the femur, and it does so. This guy doesn't have one. So patella, femur, here. So if it's torn, then the kneecap can jump over here. If it's there, and it's as taut as it's supposed to be, the kneecap can't go anywhere because this is its anchor. It's holding it in medially. Why does the patient come to see me? They can have, obviously, dislocation that stayed. So you may see them like in an emergency room or an urgent care because it's still out there and hasn't gone back. Or it could have gone out, and then when they straighten their knee, it flopped back in. And they're just complaining that that happened to them and they didn't like it, which makes sense. Acute hemarthrosis, pop, seems pretty typical of what happens when things move. And a loss of motion, because their extensor mechanism is like way weird. How does it pull when it's all biomechanically weird like that? Patellar instability, they can say that they have things with quad activities. Same quad activities we talked about a minute ago. So stairs, this one's descending. Theater sign is what we call it when they have trouble either sitting in a theater. This is old school theater, not movie theater. Like where they were there for hours and hours and hours sitting in the same seat. So we find that more with car rides, when we go on 6-hour car rides. Movies, unless you're watching a Lord of the Rings extended version, we're a little too short these days. And then squatting, quad activities. Okay, what do we see? So we're going to go fishing for instability. So we can check if they're tender to palpation of that medial patellofemoral ligament. Again, it's coarse. We're going to use you. Sorry, sir. Okay. So again, it's anchoring here. They're tender along that. And then our big test is the apprehension test. So that's what's on the far right there. So in the apprehension test, we're pushing pressure here, and then we're running them through range of motion. And it was even on the model, as I tried to push that and I moved it, it snapped right back into the middle of the trochlea, even just as I did that. But as you come up and you keep pressing it in that straight position, that's when it's most likely to escape. So you can just run them through that entire range of motion and see if you can pop it over that hill. Don't worry, if you do, you just put it back on. And I go, ah! And you go, yeah, you got a problem. Okay, maltracking is it doesn't just come out, so it's subluxing, but not dislocating. We can check that with alignment, and while we're on the break, I'll load that video so that you guys can see what a J sign looks like. It's gross. But then we can kind of check where the patella alignment is along the course. Okay. I'm going to get my AP and lateral. I'll get a sunrise, so that is also called the merchant or Lauren views. You don't need to know that. If you look up sunrise, it'll come, or review and see what it's included. And what we're looking at is the relationship of the patella to that trochlea. So again, the trochlea is that front of the femur. And we want to see how big are these mountains. If they're little mountains, then that supports their claim. We also want to see where the position of the patella is relative to where it belongs, centered on the trochlea. Like this curve and this curve should be hugging each other. They're the same curves. Same here and here. We would want them to be hugging each other. And so this one has that resting lateral position. So it's way over there. This person also has a nice shallow trochlea that probably isn't assisting. I'll take that off so you can appreciate kind of that alignment a little more. I've got my marks all over it. If this patient gets to MRI for any reason, concern, failure of non-operative treatment, we may see bone edema or inflammation where those two surfaces keep spending too much time with each other. So the medial patella and the lateral femoral trochlea. So if they're spending too much time, then we would be able to track that as well. We can also use that to look at that MPFL injury, should that be of concern in an acute scenario. Where do I start? Rest, ice compression, elevation, anti-inflammatories, activity modification, physical therapy. If they have an acute injury that's leading to this, so they were doing X and then they came in to see me 2 days later, I can start with this acute patellar subluxation. Allow bracing, doing some modified weight bearing. We would do that up to 4 weeks with a range of motion brace, something that stabilizes their patella to make sure that it doesn't keep trying to escape, and let that bone edema heal, let the system calm down. If this is a chronic problem, they come in months of complaints of subluxation, we need to get them more focused on rehabilitation. So quad strengthening and flexibility, maybe some bracing to control patellar motion. So it's one of those patellar motion braces. It's got a big patella ring on it to keep it centered. And that's all through physical therapy. Namely, we focus on the medial quads and strengthening those so that they can naturally pull that patella back into the middle of the trochlea. It's a lot of body weight stuff. Okay. Operative, we can go in and do a reconstruction on the MPFL if they have an acute tear to it. If it's a chronic tear, it's not reconstructible generally, but new technology comes up all the time. And then the other option is another realignment osteotomy. This one is different than the one we talked about, but has to do with kind of where I opened, which is that version or torsion. So they cut and they twist so that they can recenter part of the trochlea and unload that joint. Things that happen because of our treatments, recurrent symptoms, even though we treat them to the best, and then a non-operative treatment failure. So we'll pause there. I'll grab the J sign video while you're on break. If you that J sign as the patient moves through their range of motion. Okay. So motion of the patella medial lateral as it runs through its range of motion. J sign. Anything else we need to go over before we resume? Okay. We're going to continue our patellofemoral complex discussion with patellofemoral pain syndrome, or PFPS. More angry redness between the femur and the patella. It is the same area. So the same articular cartilage that was complaining in the last complaint is still complaining. Origin is just different. Severity is different. So this one's anterior aching, diffuse pain. This is an overuse injury. Has to do with those two surfaces spending way too much time, with words right now, moving against each other. That still sounded bad. Related overloading of the patellofemoral joint, so same activities that we talked about with the quads as we go through this. You may hear this by older preceptors called chondromalacia. I would like to provide a word of caution with that phrase. So that chondrocartilage malacia means bad forming. You cannot give a patient a diagnosis of chondromalacia unless you have had a tool in there and you poke it. And you say, ooh, bad cartilage. So although it is an ICD-10 code that you can employ, try not to employ it unless a surgeon has already employed it on your behalf after they went in and they squished it and said, ooh, that's bad. They didn't say that right because you're not supposed to say things like that in the OR. They say that's chondromalacia. Okay, anterior knee pain, we're seeing same things that we've seen previously, theater signs. So anterior knee pain with prolonged sitting, quad activities, climbing the stairs, jumping, squatting, same quad activities we talked about. These patients, because it's not necessarily pulled over to the lateral side, they actually have more medial pain as well. So when you say, where do you have your pain? Can you point to it? They'll draw a circle around their whole patella, kind of indicating that it's all that cartilage that is yelling, not just maybe the outside cartilage. Corresponds with an increase in activity or an increase in weight training. So squatting with more weights, more forces. And they may have a history of a direct blow to the patella. Then you kind of need to work it up based on kind of where you went in this spectrum of pathologies. Luckily, there's a lot of overlap, so you'll eventually find your algorithm for this. So gait is our first assessment. We look from the front and we'll look from the back to see what their kneecap is doing as they walk. We want to see if they are flat-footed or overpronators is probably a better term, or that they're knock-kneed. So they walk in valgum. Patellar grind test in terms of physical exam. So they'll put that, you can do that quad active patellar grind where you smash their patella into their trochlea and then have them fire their quads, smashing it further. Or you can just do the regular one where you wiggle it around within the trochlea and see how much it hurts them. We were talking in Clin skills, you can make a patellar grind positive on anybody if you provide enough pain, pressure, okay? So these people will have pain with less of that pressure. You don't need to go and just dig it on in there. That will hurt. You can apply the downward pressure or the quad active and they can decide the pressure. Now tracking and instability, those would fall under the other category. So we would segue from this. If we had apprehension or the J sign, those would fit better with the previous topic. Okay, diagnostic films. So same films we got for our patellar instability. So AP lateral and sunrise. We're looking again at the relationship of the patella to the femoral trochlea. If they have a shallow trochlea, again, that would increase our understanding of what forces are interacting. And then a lateral resting position of the patella could support this, even if it's not bad enough to put them in that instability category. This is the same picture, just in case you wondered. Same picture. So where do I start? Same place. Rest, ice compression, elevation, anti-inflammatories, activity modification, physical therapy. Physical therapy becomes our hallmark because there's no MPFL to necessarily go in and intervene. So we're going to work on how their quads interact, how their trochlea cartilage is. If they are doing, so patellar pad, knee sleeve, or taping, those all have to do with how we stabilize the patella in 3 dimensions. So a sleeve would, have that, we could talk about the one with the patellar hole where it holds it right there in the middle. Taping could hold it medial or lateral, depending on how the taping technique is. So we could use any of those to help provide additional stability to that extensor mechanism as it glides through. If they are obese, we should talk to them about weight loss to help decrease the forces and modify how much stress their knee is under. Adverse outcomes of the treatment, so aggressive quad activities need to be held later in the protocol. If we go too aggressive too quick, we can rupture things. Patellar tendon, quad tendon. So we have talked about all of these things thus far. At this point, I'm going to give you about 15 minutes to do life and take the quiz, and then we'll go over the plica, and then we will pick up with the rest of the things that we need to talk about, where we're going to start talking about the rest of the adult complaints, which are plica, posterior cruciate ligament tear, and shin splints. We won't get to all of those today, and then we'll launch into the pediatric dominant complaints, which starts at bipartite patella. So if right now you could go to the quiz and take that quiz. Here in about 15 minutes, we'll debrief it. And then we'll go on.
Quiz 5? 6? I don't know.
It's 5?
You never really ready. Yeah. Delete something. Quiz 5. I was quiz 16 before quiz 5.
I tried rolling them off them as we talk about them.
Oh, she unlocked something. Oh shit, let's do tomorrow. Oh my god. Shut the fuck up. It's cumulative living.
There's no way I got 100 on that shit. That's where that fits.
Like departments with the test issues, I have one slide for each extremity, about which drawers are attached to each test, and just split that top of the thing and said, on tissue the whole time this. That's like just, I guess. All right, innovation in fascia. I just sent them all out of the meeting and just thought I'd ask you to just make this finish the that I like, and I'm just keep going on and get it and just get it. You have to slide them to program. Okay. And we just, whatever you set this
For my brain to feel not just
slide. And then
those two besides like besides having to deal with moving the entire household and shit like that. It's wild to me that we can get 2 weeks to be able to. Oh, we're gonna be in process for a while. So we don't start right.
Nobody's working.
it started like
And then the next day, we're gonna go in once a day,
everything like that.
and then a 72 starts.
Sometimes,
Just let us check it out.
and that way, like as I'm going through the slide deck, I don't have to do that much work.
But you keep all the slides you've done. You don't pull out some
Yeah, and then when we go through review, I just show the entire slide. That's pretty good. Because it's like a mix of both, right? It's radiation class, and then theoretical. It's in our college together, and she's driving.
Where's your fix to say? Where? New
And
York.
then has some
Like, that's a drive.
doing that for us, but
In the snow?
yeah.
Typical to go West Point though.
Slide master.
There's probably nothing else, like, no other military besides the students who. You're gonna have a bunch of smart people. You gotta be smart to get to the academy. Or you just gotta know. You gotta be book smart. You just gotta. No?
He puts his words all lines up versus all over. Yeah, that's like,
That's how I started. I just wasn't able to figure it out. How to do it for students. It does, but it's like this way.
Okay, let's go ahead and resume by going over our quiz, debriefing. Nice job here. So radiographic view we're looking at here. So Merchant, Warren, Sunrise, all those are true. Pausing because I failed to turn back on the thing. Thank you. I would have just kept talking to you guys like, stop, you can't see it. Okay. I also like this picture because it shows just how far in this particular view you have to, the fibula is for that, which is lateral, which is medial. That one is normal. See how it's all nestled right there in the center? Surfaces around it are all look equal. So, nice job. That's one question, so good job. There's another one of those that I am equally impressed. Okay. Hold on, let's do it. Which of the following is the next step in managing this patient? So we're looking through consult vascular, consult orthopedics, physical therapy, neurosurgery, orthotics. Okay, well that's weird because we haven't talked about consulting orthotics yet. Take that one off. Okay. Emergency department, hysterical. Well, sounds like it needs a surgeon right off the bat. Okay, let's see if she really does need a surgeon. For the last 30 minutes, she's been unable to move her knee. She has been followed by orthopedics for ACL laxity, and an initial knee exam cannot be performed due to patient anxiety, not pain. After you sedate, you find a fixed knee joint. So she's sedated, she's not helping much. So these are a lot of past things. Fixed knee joint at 45 with extremely limited range of motion around that point. Neurovascularly intact. Urgent MRI shows an ACL tear and a vertical longitudinal tear of the medial meniscus. Which is the next step in managing the patient? So the part that matters the most is the fixed knee. So nice job there. She needs orthopedics to get that undone, and then eventually they'll fix all the other stuff, the ACL, do rehab, all that. So locked knee, what drove that? Okay. Radiographic finding in this radiograph below. Hey, look, it's the same picture, only flipped. That goober right there. Okay, so that's patella baja, way low. Patella alta would be if the whole patella was up where the goober is. Yeah, those are technical terms. I get to talk about those in my ClinCore group. Sorry, ClinCore group. Goobers. Okay, so if everything were up further north, then that would be alta. This one is baja. Plateau fractures, we have not talked about them yet, but if you're concerned about this thing right there, that's a legitimate thing. I don't think this person has both. I just think that they have a weird radiograph. I could correlate that by getting an orthogonal view and or going to CT. Bipartite patella, we'll talk about that here as we continue on our lecture. You can see it in a Sunrise or an AP. following is demonstrated in the imaging below with a positive green arrow. This one looks a lot like the picture, the little illustration with the sclerosis and the empty circle. So that is medial femoral condyle, helps with location. We say, okay, that osteonecrosis of the femoral condyle more common medially. Yay, you did it. Woo. Yay, I've got compartment syndrome again. So block 1. Fasciotomy scares the crud out of us, but that's where we're going. Image below. So we have positive arrow sign, positive arrow head sign, another arrow. Those are 2 views within meniscus tear. So the little triangles, remember those are our meniscus, the black triangles, and when we see fluid signal going through the triangle, that is our meniscus tear. If I thought I could do better than the arrows at identifying that with this pen, I would totally try, but it's not going to happen. If I were going to see a PCL tear, we could still see it on the sagittal view, but we would need to go to the middle of the knee where we can see that nice hooked PCL and the straight ACL. MCL and LCL, we like the coronal view, and then we would see that happening outside. So the fact that you get 2 kind of helps look at that orthogonally. Radiographic finding below, well, it's the opposite of the one we saw before. So again, our measurement is where the trochlea ends. Trochlea ends right around here, which means our trochlear cartilage on the femur and the cartilage that's supposed to articulate with it are not talking barely at all. Osteonecrosis of the femoral condyle that then went on to fail conservative treatment, meaning that NSAIDs, rest, ice compression, physical therapy. This patient even got an injection. So a lot of surgical options here. Reconstruction would be a term we more use on our tendons and ligaments in this block. Amputation, good job guys, not choosing that one. Don't take it off, it's okay, I'll fix it. Meniscectomy, arthrodesis is fusion. We're going to do that in block 4 more. So arthroplasty or a joint reconstruction is joint replacement, pardon me. See, I use that word because that was, okay, last question. Which of the following is the most likely diagnosis? Not helpful. 42-year-old male presents to clinic complaining of anterior knee pain that's worse than playing basketball. Thank you, sir, for doing the jumper's knee thing for us. Pain located inferior pole of the patella. Full active range of motion at 5 out of 5 strength. Yay, nothing's broken. So full leg extension. Okay, so we've got most common. We've got a nice sport that goes with it too. Oh, I crossed it out. Sad. Okay. So patellar tendinitis. Hey, look, I spelled it right that time. Tendinitis. Good job. Okay. Quadriceps tendon. Pain should be on the superior pole, if that's where we're going. Meniscus tear, I would describe that as joint line pain. So medial meniscus tear would be on the medial joint line. Lateral meniscus tear would be on the lateral joint line. And then prepatellar bursa, I would probably describe where it looked like or do a picture. Because describing it would be hard. Questions there before we head back to blah, blah, blah. Okay. That was not what I wanted. Sure, well, we can use that. That's great. I duplicated it. Now it's the same on both screens. Okay, a plica. Plica is the way I've heard it in my experience. If you hear it pronounced a little differently, don't get too out of sorts. Okay, so how does one get a plica? Okay, when you were a fetus and your knees were up by your ears and you were all scrunched down, you needed a lot more joint capsule than you need today. So you had all this extra joint capsule that when you got out of that position and you started doing things like crawling and walking, there was too much joint capsule. And so that joint capsule, the synovium, folded over to take up that slack. Now, in most people, that isn't a problem. But some people make that tissue super hard, and it becomes symptomatic. It becomes inflamed from trauma or overuse, and I'll tell you about the use here in a second. There are more than one plica, but the one that bugs people the most is the medial plica, and that extends from the medial joint line capsule to the anterior fat pad, kind of in this arc. Oh, here, let's do it on our dude here. Hi, dude. My index finger. Now, this is activity-related pain, and it's anterior and medial. And it's also a little proximal to the joint line, and I'll talk about that in a second when we get to physical exam. What's happening is that as they bend their knee, the shortest distance is for it to come medially to the medial side of this ridge on the condyle. And then when they extend, it comes back towards the lateral side. And every time they do that and it snaps over that little ridge on the femoral condyle, it kind of makes a snapping or a popping sensation. Every time that it moves, they get that sensation. The problem with this is if they keep doing that for when it hurts and they suck it up and drive on in Army lingo, you can actually sand down, you can erode the femoral condyle by doing that, because every time it goes over, the body's saying there's a thing in the way, and eventually your body will try and make that thing go away. And that thing happens to be a femoral condyle, which you sort of know. So with the tenderness to palpation with a medial plica, it's going to be medial to the patella, so that's superior to the joint line. And you can kind of feel the ridge of the condyle there. It's even a little more proximal to where we had our osteonecrosis of the femoral condyle pain. But we are talking about centimeters here. So it's not like we're talking inches and inches, just a little ways. And then you may be able to appreciate that popping or snapping sensation when you flex and extend your knee. If you put your finger over it, you may be able to appreciate that tissue band moving from one side to the other. Plain films for this, they're not going to show anything unless they've really eroded down their femoral condyle, which would be a long ways down in their treatment plan. And then an MRI would similarly be normal unless they're causing a lot of damage to that section of the condyle, and then it might have bone edema. What do we do about this? Well, that sounded pretty lame the way I talked about it, so I'm going to go with our lame category. Anti-inflammatories, rest test, compression, elevation, activity modification, physical therapy. Great place to start. Steroid injection can help us with that therapeutic diagnostic part again, because this is within the joint capsule. So if I numb the joint capsule and give them some anti-inflammatory, I may be able to elicit a change in their pain. That picture is an arthroscopic picture of a plica. The plica is 3. 2 is the tibial plateau, so we're looking at the space there, and 1 is the femoral condyle. All of that pretty little white hair, that's the cartilage of the femoral condyle that's being eroded away by that band 3. So it is the sandpaper to the 1, which is the condyle. Your knee is not supposed to be quite so pretty on the inside. It's supposed to be all smooth. Look like a cue ball. Okay. Operative treatment, we can go in and do an arthroscopic resection of that plica, which is what they're doing in this picture. If it continues to be pathologic, even with our conservative measures. And they just basically go in and shave that entire section out and take out all that redundant tissue so that it's no longer quite so fibrous or quite so irritating. Okay, I think we'll talk this one and it'll take the rest of the time. Yep, that seems good. Okay, so this posterior cruciate ligament section covers 2. Straight posterior cruciate ligament tears, or PCL tears, and then multiligamentous knee injuries. So So what does the PCL do, first of all? So it controls posterior translation of the tibia. So when I try and force this way, so my pressure is coming here, okay, that's the PCL's job, is to stop that. So anytime you come up with a mechanism of injury that replicates that, then that's going to be something that causes them to have a problem. So they need to be able to move that proximal tibia posteriorly with enough force to try and get it to stop, and then push through that stop to tear it. These are less common than an ACL tear, and people function without PCLs at a near normal level because it is not as important as the ACL. You don't use it in most everything you do in your daily life. So how does one apply this much force? So dashboard injury, so that's when you're riding in a car and the car comes to a sudden stop and or you do not, and your knee is in that bent position and the dashboard strikes you with the tibial tubercle. Okay, if it hits you at the patella, it's not doing anything except for hurting your hip. But it's got to strike kind of there at the tibial tubercle, forcing your knee into that position. Fall onto the knee with a plantar flex foot. So you got to take your toes out of it. So bring your foot into plantar flexion and then crash down onto your knee again. That tibial tubercle, if that's what's taking the force, that's what's going to cause the posterior translation. Pure hyperflexion injury, it's because, again, when you bend your knee that much, that's kind of all you're relying on. Less common, obviously. Most of it's how do you hyperflex your knee that much without getting your quads and your bummer involved. Hyperextension, so you get an ACL rupture and then you hyperextend. Well, it's the only guy left in there, so it tears, and it's sad. Okay, so that last one is how we earn multiligamentous knee. Knee tibiofemoral dislocations tend to spontaneously reduce when layperson sees you laying on the ground screaming and your leg's in a bad position and they put you back into normal in a hope that you stop screaming. Okay, when they put you back into normal, it tends to go back to normal. It's not always, but you've got enough stabilizing muscles around that it can spontaneously reduce by being placed in that position of function. Holistically, effusion and limited range of motion, remember these are intra-articular, so we've got that hemarthrosis going on after the tendon tears. Feelings of instability, not our most common patient complaint, but can be possible in certain types of sports players. They have to really work on it though. Okay, adverse outcomes of the disease. Multiligamentous knees, popliteal artery and the tibial nerve. They don't like being stretched. They are at risk for traction injuries because of their posterior location, chronic instability, and changed biomechanics which result in osteoarthritis. Again, physical exam, you may note that there's a hemarthrosis. You could draw it off, help treat your patient. They're going to have some decreased range of motion because this hurts. If it is just the PCL, our tests are posterior drawer, sensitive and specific, limited due to guarding the first few days. So just like the ACL with the hamstrings and the gastroc and soleus stabilizing the knee, that holds true here, the PCL as well. So if they're guarding, they're going to stabilize their knee. And then PCL sag. So PCL sag is this. And sorry, yesterday we did clean skills and this is what we did. So my brain is like, wait, did I tell them this? No, I didn't tell you this. Okay, so posterior drawer, we're in that same drawer position at the knee. Knees at 90 degrees. We're sitting on their foot to stabilize their distal extremity. And instead of pulling, which is what we did in an anterior drawer, this time we're pushing. We're leaning into the knee. And we may find laxity when we push and it stretches out that. There's no constraint to the system. PCL sag means that the resting position of that knee is posterior to normal. So because there's no posterior constraint, when they get into this position, gravity takes over and it pulls distally. So the way how we got into this conversation yesterday was in clin skills was the quad active drawer test. You guys remember he brought that up yesterday as well? Okay. So the quad active drawer test takes them from that PCL sag position that's in that bottom left thing. You engage the quads, so you pull at the tibial tubercle and they come to normal. Meaning that as I have them engage their quads, their tibia comes towards my face. Okay. It's an important thing to know as a beginner because when I do a drawer test on that PCL sag patient who is in that resting posterior position and I pull it towards me, their tibia is going to come towards me. But did I just anterior drawer them or did I take them from weird back to normal? Okay. So that's kind of what the quad active drawer test brings to you is where did I start? Okay, so yes, you could have some dude who looks like this and you're like, oh yeah, your PCL is totally out. Okay. But if it's less subtle than that, having the quad active drawer test can help you see, did they come from a resting posterior position to normal? If a patient with an ACL tear does a quad active drawer test, nothing happens. There's no motion in the proximal tibia. They're already at normal. So that kind of helps you tell when you grab a proximal tibia in a drawer position and you pull it and it comes towards you. Is that a PCL tear or is that an ACL tear? That's the power of the quad active drawer. And if you have questions with all that blah, 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 I'll let you ruminate on it, talk about it again. We need to rule out other ligamentous injuries, ACL, collateral ligaments. This is a knee that's in a lot of pain, so you can kind of see where we're going with our imaging here. I'm getting there faster. Okay, multiligamentous knees, that is limb threatening. I said there was a popliteal artery and a tibial nerve. That's limb threatening. So you need to do your neurovascular exam as well. So if you have any reason to suspect a knee, a tibiofemoral dislocation, you need to do a neurovascular exam. And then we're going to employ an ABI again to see how the blood flow is doing to that area, arterial blood flow. So refer back to that slide. Abnormal is still 0.9. AP and lateral of the knee, we may have bony avulsion of the PCL. That's pretty less uncommon. I don't want to say pretty uncommon. That makes it sound more uncommon than it is. MRI, we got there pretty quick, right? You got to rule out all those other pathologies. The more significant the injury, the more quickly I will come to this MRI conclusion. PCL, in that extended knee position that we have when we lay in an MRI position, so we're laying in that tray, going in and out of the MRI machine, it's lax. Okay, so a normal PCL has a curve to it. Now this one just has a curve with some balls. That sounded bad, Robin, gosh. I'm gonna work on that language later. Okay, so those two, we're worried about this, the white signal that parallels these lines. And I would scroll fore and aft to see where it was, if I could follow the strands of the PCL. Isolated PCL versus multiligamentous knee becomes our knowledge point for where we decide to go with our treatment. If it is an isolated PCL, we start with our typical anti-inflammatory rest ice compression, elevation, and activity modification, physical therapy. We could employ that same functional brace we used on the ACL. So it's a range of motion brace that allows them to sit in the car comfortably, but then to lock it out when they start to walk so that if they get weak, they don't collapse. If we are thinking multiligamentous, or somebody who is recurrent Like they actually need their PCLs for whoever they are. Again, it is a reconstruction, can't repair it. And multiligamentous reconstructions, it's one of those things that surgeons hate to love. So in that bottom, actually I think it's on the next slide, so we'll get there in a second. Bottom right, that is a PCL only reconstruction. So it just has the tunnels that go for the PCL. Okay, adverse outcomes of treatment, popliteal artery or tibial nerve damage. See where those two screws are? Guess what's right by them? Popliteal artery and your tibial nerve, yes. Good hypothesis. Infection, prolonged immobilization leads to thromboembolism, graft loosening. It's similar when we talked about ACL, recurrent instability as such. So the whole, love to hate it. Now that's a multiligamentous knee, so that's a tibiofemoral knee dislocation. Ew, that's gross. That's not what a leg is supposed to look like. Okay, I see like a kneecap sticking out, and oh, okay. But each of those radio-opaque screw-looking things is an interference screw holding an end to a reconstructed tendon. There's PCL, ACL, MCL, and LCL. That's what all those screws are for. Basically went and Humpty Dumpty this guy back together again with probably cadaver parts because he doesn't have enough parts to make that happen. You notice where his patella is still in that radiograph. Kind of worried. Maybe they should have thrown one more interference screw in there. Why is his kneecap still in the Baja position? I forgot something. Okay, so grossness. Ha, yeah, right on time. We'll begin, let's see here, Friday, right? Friday we'll talk